Thanks, Tina. As Tina said, my name is Jess Kolis. I am a health communication specialist on the demand for immunization team in the Global Immunization Division at US CDC. I've been deployed full-time for a year working on the COVID-19 pandemic. I have worked on our Joint Information Center social media team, supported the 2020-2021 flu vaccination campaign, served as the first social media lead for the vaccine task force, and now serve as the co-lead for our insights unit on the vaccine confidence team. Even before we knew what we know now, back in late December 2019, in my old day job, where I managed social media and the CDC flu Twitter handle, I began to see our handle getting tagged about reports of mysterious pneumonia in China. The tagging only intensified, and I was actually tasked to pull notable tweets to send to my supervisor, in addition to my daily monitoring for flu-related conversations. Little did I know, did we all know, that we were facing the beginning of what we hope is a once-in-a-lifetime pandemic. After the COVID-19 pandemic emerged, media consumption in the US increased by 60% compared to 2019. Screen time averages for adults spiked to over 13 hours a day in March 2020. Many Americans reported feeling overwhelmed by the amount of information on COVID-19, especially as they were spending more time on screens than ever before. Constantly changing public health guidance and mixed messages from authorities also contributed and continue to contribute to a noisy, crowded information environment where it can be difficult for an individual to identify what information is not only accurate and credible, but also fresh and valid. How can you know what you are retweeting or sharing is still right? Why would you not share that post about a danger so your friends and families know to avoid it? Misinformation spread during the COVID-19 pandemic here in the US has led to increased calls to poison control centers due to the misuse of household cleaning products, ingestion of bleach, and improper use of hydrochloroquine. As the pandemic has progressed and vaccines came into the conversation, misinformation began to spread about COVID-19 vaccines too. Organized anti-vaccine groups have taken to collecting stories of individual tragedy and using them to convince others to see themselves there and to join in their fight for what they call medical freedom. Where high vaccine uptake is essential for us to move closer to the end of the COVID-19 pandemic, maintaining public confidence in vaccines, vaccinators, and the health system is critical. Addressing the COVID-19 infodemic and the misinformation around vaccines is paramount, given the critical issues with vaccination on a national and global scale. Misinformation about COVID-19 vaccines is especially concerning as it seeks to polarize the topic and exploit people's and communities' fears and distrust of governments and health systems. It also makes it difficult for people to find, distinguish, and act on credible information. However, chasing individual pieces of misinformation in attempts to debunk them ignores the real, larger social and cultural forces that cause these pieces of information to emerge and gain traction in the first place. Understanding themes of misinformation and information gaps that exist, and then developing programmatic communication approaches that address these underlying narratives is critical to better addressing the challenges of the infodemic, and is especially important in my work to promote vaccine uptake here in the United States. As I said earlier, I have been deployed in a few roles on the COVID-19 response. My most recent role, co-leading the Insights unit, came out of a need that developed when I was the social media lead for the vaccine task force. I was facing my own personal infodemic. It was difficult to balance being responsive to the information gaps and misinformation I was seeing spread online and the outpouring of new content from our task force, while also trying to balance the message fatigue that consumers were facing. Social listening tools that we've seen some great new ones today that are more appropriate, but social listening that many of us have access to now are not built to help us track and recommend actions around public health crises. So after many late night brainstorming sessions with Liz Wilhelm, our Insights unit was born. Our Insight unit is currently staffed by 2 co-leads and 3 to 4 full-time analysts. Our key product is our bi-weekly COVID-19 State of Vaccine Confidence Insights report. The report looks at multiple sources to help us better understand the communication landscape surrounding COVID-19 vaccines. To develop the report, we look at social listening data from our social listening tools, as well as hand search closed network and social media platforms. We analyze comments on our own social media channels. We monitor stories in the media and track the media requests we see coming in, review current polls and new research published in peer-reviewed literature, look at research and polls that we're doing ourselves, analyze calls and emails into CDC's call center, and track web metrics. After collecting and analyzing each of these inputs separately, our team comes together every other week to triangulate and synthesize what we are seeing. This is especially important as it allows us to weed through the noise and figure out what major themes are rising to the top in this hectic digital landscape. Our process has become more streamlined with time, and we are now better able to identify emerging issues before they become major themes. This work is part science and part art, as there is no way to determine what necessitates a threshold for a theme or emerging topic. After we review all potential themes, my co-lead and I review all of the team's notes and put together an outline of themes, emerging topics, and continuing topics, and circle back. From there, our team determines the threat level of each identified theme as it relates to vaccine confidence. We are currently working on a code book in order to make this a more formalized process, but as of now, we've had 4 levels emerge for us to code and provide context to our readers. We look at each theme and determine whether it's high, moderate, or low risk, and in some cases, whether it's positive sentiment. High risk, we focus on items that could lead to vaccine refusal directly and will directly affect the uptake of vaccines. These are also themes that are typically have a wide reach and are pervasive in the digital environment. Moderate risk may not have that direct initial reaction, but will trigger hesitancy, and they tend to not be as widespread as high risk. Low risk, they are items that are concerning and could have impact on vaccine confidence overall, but are typically reserved for themes that are not widespread or have an impact that may be limited into a smaller subpopulation. And our newest addition, as I said, was positive sentiment, which such far we've only been able to use once, but allows us to highlight when positive themes are just as pervasive as themes that threaten vaccine confidence. After this, our team considers the directionality. We look at conversation volume, share of voice, and percent change from one report period to the next. This is helpful for context to allow people to see whether these conversations are on the rise or have remained stable over time. But as other topics have fallen in prevalence, a particular theme is now standing out. Our team then pulls all of the appropriate information into one place so my co-lead and I can write narratives. These narratives synthesize all of the data and showcase the perceptions of COVID-19 vaccinations and how they might impact confidence. However, what makes our work different than typical social listening and media monitoring reports is that alongside the narratives for each identified theme, we share ways to take action and address the information gaps, perceptions, and rumors that may have led to these themes emerging in the first place. The ways to take action typically fall into 3 categories. First, communication. What content or information is missing? What messages do we need to disseminate or amplify? What messengers do we need to work with to do that? Second is programmatic. What can we do to improve upon the issue? Do we need to create a website, identify a new process or system? Is there a particular barrier that we need to address? And lastly, research. What do we still not know that we could learn from a survey, focus group, or a listening session? What do we need to know in order to produce better communication and programmatic opportunities? This is the most important part of the report. At the end of the day, we want to report to find its way to people on the ground who can quickly take action. At CDC, we have a direct link to our communications team on the vaccine task force. They take each of our communication recommendations and break it down into actions to improve our agency's communication efforts. From putting together a prepared response to a question that has emerged or a misperception that has grown, to expanding web content, to informing our social media editorial calendar, we have seen this report directly impact our task force communication efforts. With our distribution list growing by the day, the overwhelming feedback we receive is that this paints a picture that not only validates what many people are seeing or hearing anecdotally, but that our ability to find misinformation and perceptions that are in the middle of the pack and highlight them helps health departments and organizations know where to focus next, what the needs are going to be, and focus more towards social inoculation space we need to be in. Since the report began, we have seen a conversation shift and change drastically. Our first report heavily focused on how frustrated consumers were with the state and jurisdictional eligibility and the lack of clear communication about who is eligible for vaccination and why. However, the groups who were eligible were facing systems that were difficult to navigate or were not able to handle the high volume and demand that did exist. We even saw the beginnings of conversations related to the impacts that virus variants may have on vaccination efforts, which, coupled with a large need for better education around what vaccine effectiveness numbers meant more generally, was particularly challenging. We also saw the beginning of confusion about maintaining mitigation measures after vaccination and confusion about what we did and did not know at the time about asymptomatic transmission among those who have already been vaccinated. This was especially challenging as it began to make many people think that vaccines were not a path out of the pandemic and into normalcy, and challenge the benefits of vaccination, which for many is the most powerful internal motivator. The confusion about vaccine benefits continued into our next report, where we were seeing people more confused about whether one shot might be enough or they needed two, or did previous COVID-19 illness play a role in whether they needed to be vaccinated at all, or did they just need one dose? With new studies on vaccines coming out, what feels like daily, research findings and official recommendations were getting lost in translation, and consumers did not know where to turn or what they needed to know. By report 3, this led to us seeing conversations about people wanting to mix brands of vaccines in order to increase their effectiveness, even though that's not how it works, and people begin to even start shopping for particular brands that they thought would be best for them. And now at report 6, we are seeing the beginning of vaccine supply exceeding demand in the United States, which has triggered conversations about hesitancy, and that has become front and center on all media outlets. However, this was different than before. Their messages now are on how demand issues may make population immunity impossible to reach, which makes vaccination seem not to be a viable option to return to normal, which goes back to where we started. I'm not going to lie, this is a lot of work. There is no silver bullet. It is also an imperfect science, and one that is very much in its infancy. We were able to recently test our system with the pause of the administration of Johnson & Johnson Janssen COVID-19 vaccine was announced in the US in mid-April. Using our same methodology, our team did a rapid insights report over a 3-day period that focused on understanding consumer perceptions, concerns, and the overall threat that that pause had on vaccine confidence. We also unpacked content gaps that emerged the day of the announcement and following the CDC's advisory board meeting a day later. And then what information was then also being spread as a result. Since the target audience for this rapid report was our own federal agencies, we laid out directly what the US federal agencies could do to reduce the impacts of the pause on confidence in COVID-19 vaccines. While this was not easy or quick, the process we followed was the same step-by-step process we do for all our reports. It showed that the mechanisms we have put in place allow us to act quickly if there's an immediate event that needs monitoring or a pulse check. And we know that creating a robust system is essential for us as we build systems that can do this work far beyond COVID-19. As we all build out our systems and work together to build better systems, it's important that we focus on how to build a system that is robust and sustainable. This work is not going away, and I know I'm preaching to the choir. It's only getting larger as our digital world expands, evolves, and becomes more complex. But it is possible, and our ability to reduce the harm and misinformation because of all this work is worth it. Thank you all so much for your time. If you are not receiving our COVID-19 State of Vaccine Confidence Insights report and you would like to, you can email, I have it on the screen, eocevent515@cdc.gov. I really appreciate the time today and excited to take your questions.